All right. Can everyone see the test?
Yes.
Perfect. And we're recording. Awesome. All right, for those who just joined us, I was kind of talking to some of the students prior to the start of class. I'm going to go ahead and go through last week's test. I wanted to give some quick statistics. So the lowest scores on the test were a 66. The highest was a 98. The average was an 84, and we had a median of 85. So we definitely had a drop in class average, and I know some of the material could have been confusing because it could have been both people, it could have been one or the other. So I just want to hit this test hard. And actually what I'm going to do is I want you to email me with the questions that we go over today and go, hey, we talked about these questions today, and I think that I deserve 6 or 8 points more. Does that make sense? It kind of puts you as a student as responsible for fighting for your grade on this exam. You guys are all doing wonderful in the class, so not a big worry there, but there are some questions here that I think are probably controversial and can be more than one answer. So who is responsible for checking the surgeon's preference card? So that is both. You as a scrub tech, check the instrument or check the preference card for what type of instruments are needed, what type of gloves, what type of suture, helpful hints, right? We watched that video last week. Next one, who is responsible for wiping down the room? Oh, and I'm sorry, I wanted to go back up here. The nurse then will check the preference card, and she checks it for positioning, any extra items that may be needed for the procedure, such as x-ray or specific requests for pathology maybe to come into the room, things like that. Also for medication, so she'll be pulling the local. Second question, who is responsible for wiping down the room? And that's both. It truly is a team effort. You and your circulator work together as a team the whole entire day from 6:30 in the morning until 7:30 at night if you work 12-hour shifts. Who identifies the patient? And that is your circulator. Sorry, I went up a little. There we go. And she identifies the patient when she goes to get them in pre-op. And that's where the initial identification occurs. So we definitely identify them again in the time out, but the primary identification is done by the circulator in pre-op. Who opens the sterile supplies and instruments to the back table? And again, that's both. Your circulator will be right there with you, opening up instruments for every single case. Okay, and if there's a question that you kind of want to talk about or discuss, or you think you deserve 2 points, I want you to verbally interrupt me, just because I can't see if you write something in the chat. Who is responsible for protecting the sterile field from contamination? And the answer was surgical technologist. Any questions or concerns? No?
Yeah, I think that also the circulator has this responsibility. So everybody in the OR needed to protect the sterilized field.
Perfect. So it's both, right?
Yeah.
Awesome. That's exactly what I wanted to hear, Lysandra. So essentially, during the case, inside of our AST book, it has that everybody's supposed to be watching for breaks in sterile technique, et cetera, et cetera. However, it is a surgical technologist's responsibility for protecting the sterile field, maybe while the circulator is on the computer, et cetera, et cetera. But this is one of those questions that I feel like is absolutely controversial and could be both. So if you chose to answer both on question 5, I'll give you 2 points. Send me an email, okay? Keep track of these questions and then send me an email and say, hey, I picked answer C, which is both on question 5, 2 points there, and just kind of list them out for me. Who needs to don appropriate operating room attire? So appropriate operating room attire, scrubs, appropriate shoes, a hair net, and a mask. So that is both. Who is responsible for checking and connecting electrical equipment to the power source? And that's your circulator. So the electrical equipment and the power source is not sterile. So someone who is not in the sterile surgical team or not a part of the surgical team has to do that, which is your circulator. Who organizes the back table? That's your surgical technologist. Who ties the gowns on sterile?
Sorry, the number 8 is not both. Because if the circulator helped me to open the sterilized instrument, he helped me to organize the back table.
So that's a great question, Alessandra. So your circulator will help open instruments, but they will not scrub in. So your back table is entirely sterile, and your circulator never scrubs in to help set up those instruments or organizes.
Oh, okay.
Does that make sense?
Yeah.
So your circulator absolutely helps you open, but they will not be ever touching your back table to organize it. That's entirely on you as a surgical tech.
Okay.
But good question. Don't hesitate now on the next, 42 questions or whatever. Who ties the gown on sterile team members? So when you put on your gown and gloves, you as a scrub tech will put on your gown, your gloves, and then the circulator will tie the two little, they're like strings or pieces of fabric on the back. So there's Velcro up by the neck, and then there's two little strings that they tie right behind your middle back. And then you pass them that little tag that has another little piece of fabric or material to close the area in the back. And I think we'll try to watch a video on that either this week or next week, just so you guys kind of have a better idea on what that looks like. But it has to be someone who's not sterile to tie your gown. It can't be a sterile person because everything on your back is classified as unsterile.
Angel, sorry, I have a question. So here
You're all
in
good.
number 9 is not the surgery is not correct to say both, because when I assist a C-section in my hospital, the surgical technology help the OBG to tie the gown to help the OBG. I don't know if you understand me.
No, you're good. So you're saying in L&D that the surgical technologist helps tie up the gown and gloves.
Yes, I didn't see the circulator to do that. Because the circulator was
So
to do something else.
No, you're good. So here's how I kind of want you to think about it, Alessandro. If you only have a surgical tech and a circulator in the room, who is going to be the one to tie the gowns on the sterile team members? You only have one of each. So I bet in L&D that extra surgical tech is not the one that's scrubbed in doing the case. Is that correct?
Mm-hmm. Yeah.
And so primarily in a room, you only have one scrub tech and one circulator. So your scrub tech, if they're scrubbed in, can't be the one to then tie the unsterile back of the gown. Does that make sense?
Not really.
Not really.
But
So if you have a surgical tech in L&D
yeah.
and they are scrubbed in, right?
Mm-hmm.
And then you have a circulator who maybe is prepping the patient.
Yes.
Where is the surgical tech that ties the gown? Are they an extra person?
The extra person in my case is OBG.
Say it one more time.
So the extra person that entering the OR that I saw is OB.
Yeah, is the OB. So your surgical tech that's tying the gown. Now this is in the back, right? So this is the Velcro.
Yes.
And tying those two little pieces of the fabric. Are they scrubbed in?
Mm-hmm. think
they're
so.
scrubbed in and then doing the Velcro and stuff?
I'm confused. I think so, but I don't know. Okay, never mind.
If that's happening, remind me to go talk to Lindsay. So
Okay.
hold on one sec. We're gonna do this really fast because I want you to understand.
Okay.
This seaside Virgo is about to play host to an unforgettable vacation. 3 ways.
Okay, hold on real fast. I found this YouTube video. Okay, can everyone see that 3 ways?
Yes.
Yeah.
Perfect. So let's watch this video, and then I think that will kind of help you better understand how all of this is supposed to work. Big thing, Alessandro, remember, I know in L&D that there's extra people. In 95% of the operating rooms, especially where you'll be doing your clinicals, there's only a nurse and a circulator.
Okay.
We've got our open glove technique, we've got our closed glove technique, and gloving and gowning the surgeon. Stay tuned. Welcome back to another Surgical Tech Tips video. Fortunate event again, we had another canceled case, surprisingly. Usually it doesn't happen this often, but I'm glad for it. At least I can use the setup. So first thing you notice with this setup is that I have all of my gowns right there. They're all sterile on the field. I'm not scrubbed in currently, and most likely you won't be either after you set up your case. Sometimes there's time in between, you may be waiting for a surgeon or whatever the case is. Sometimes you may not be scrubbed in. So in the event that you're not and you're scrubbing back in to start this case, try your hardest to open up a separate gown somewhere else. You can open it, if the patient's not in the room yet, maybe you can open it up on the bed. You can open it up on top of a trash can, an extra Mayo stand, a prep stand, something or somewhere else somewhere else that's not going to be your sterile field. If your hands are wet, if you do a wet scrub every single time, you don't want to be dripping any water or anything onto your sterile field that you've just created and spent a lot of time working on. If your room is too small and you may not have enough room to do, to put a gown somewhere, then yes, you can take a gown off of there. I would really try not to. A lot of people do. I'm guilty of it myself sometimes if I'm in a hurry, but you should really try and not do that as much as you can. Arms are up always. Grab your towel first, open it up. Stay on one side. Fingers hand all the way out to the elbow. Use the left side of the towel, fingers, hand, all the way out to the elbow. Get rid of it. Now the gown. You notice we have cuffs here. So we're going to take the back of the gown, put our hands in the cuff, open it up, and arms go in. Your hands never come out of these cuffs. Never come out. Now, some people may have already opened up a pair of gloves on top of their gown, and that's okay. You can absolutely do that. And in fact, I think they tell you to do that in school. I personally don't like doing it that way, and my reason being for that is that this is a very small sterile field, and when you're opening up a pair of gloves, it's very easy to contaminate the pair of gloves that you open up on top of your gown. Especially if the gloves are sitting up on top of your gown, you go to pick up your gown, and the gloves fall off, they get contaminated, and then what do? So personally, I like to gown off of the field, but glove on the field. The reason being is that my hands and arms are wet from the scrub. So once I put this gown on, my arms and hands are technically protected. Yes, there's still an opening at the end of the cuff, but I'm not dripping all over my sterile field. That's the way I do it. It may or may not be the right way. I know for a fact that in school they had us open up our glove and gown in this little tiny square. In real life, though, I just find it a lot easier and safer to glove myself on the sterile field. So let's take it over there. All right, so we got our gloves on the sterile field. Remember, hands are inside the cuffs. We're going to open up our gloves. Just like that. We're going to take the first glove. First glove is going to be the right glove. They're indicated right and left. We're going to take the first glove, and what I like to do is, because these are latex or plastic, whatever they're made out of, they're always a little sticky. So I like to hold the cuff of the glove and pull on the fingers a little bit to kind of loosen them up. So we're going to take the glove from the cuff and flip it over. With your left hand, you grab the outside cuff. With your right hand, the inside cuff, and you're just flipping it over your cuff, the cuff of your gown. That's all it is. Flipping it over the cuff of your gown. Now that that's on, you kind of pull the cuff down, or pull the cuff of the glove down a little bit, and then pull the gown sleeve itself. Now be careful with pulling on the gown sleeve too hard, because these can tear pretty easily, and I've had them tear before. So now let's do the left hand. Now this glove is technically sterile. So again, I'm grabbing the cuff of the glove, pulling on the fingers to loosen that glove up. Flipping it, so my words, my numbers, and everything are down facing my palm. Holding the cuff of the glove with my right hand and the cuff of the glove with my left, and flipping it over. Pull that glove down a little bit, pull on the gown, and we're in. That is a proper closed glove technique. And that is the way.
All right, hold on. I was hoping the circulator would come behind him and tie his gown. So let me grab this video real fast.
Okay, so this is after the scrub case.
She's going to come in then. Her arms have been scrubbed and she's going to gown and glove. She needs to gown and glove off the Mayo stand. Remember we said not off your back table. And the first thing she's going to do is she's going to come in and do the towel. She's going to do it correctly the first time. She reaches in and she grabs it right at the top. So that way she knows exactly where her fingers are at all times. She's not touching that gown. Okay, she's going to reach in, grab.
So we don't want to do this. Way too close.
Yeah, so she's going to come right at the top, pull it off, step back, and she's going to unfold the towel. We're using paper towels. You're going to see paper towels and cloth towels, but we're going to use the paper towel more than likely. She's going to fold it in half, and you can see that she's bending over a little bit so the towel does not touch her gown, and we're watching for that. She started at her hands. She's rotating her arm, not the towel. She comes and she grabs the other end. Does her hands. Remember, you got a one shot. If you don't get your hands dry, your gloves are going to really stick. So spend a little time at your hands, rotate it up. Now when she hands it off, she's just going to hand it off like that and get rid of it. All right, Casey, let's do it wrong for the next one. Did you have a towel? Oh, here it is. Okay, so Casey's going to do it wrong.
Too close.
Too close. She's standing too close to her Mayo stand, way too close to her Mayo stand. She didn't fold it in half, and she's running her towel all over the place. It touched the front of her gown. Now she's just running all over the place. She's going back down to her hands, and she's wadding it all up. That's wrong. All right. Okay, so we're going to do it correctly. We're going to come in then. We're dry. Notice Casey's hands and her arms. I call them chicken wings. They're sticking out.
So remember, if you had done a brushless scrub and your hands weren't wet and you didn't need that towel, we're still going to pick it up just like I was going to dry with it right in the center. And then you're just going to take and either hand it to someone who's unsterile, staying a safe distance, or just toss it right into the trash.
Okay.
But we tend to recommend picking up the towel by itself and not trying to get the towel and the gown at the same time, because you're probably going to drop one and then end up contaminating. So I would just pick up the towel, get rid of it, and then I'm going to come in and pick up my gown.
Okay, Casey's going to do it the correct way the first time. She's going to come, see how she comes in from the top and grabs? That's how I want you to do that. Then she can peel it back. She can then use her other hand to grab hold if she needs to pull it up off the Mayo stand. Bad way is, look where her thumb is. Can she see that? Because I sure can't, except with the camera. She's going to reach over.
None of that.
Is she
Way
touching?
too close.
Even in the
Close.
front, even in the front, if she thinks that she can, and she comes in with her thumb from under the front, is it okay? No. Just go from the top, grab it. If she needs to, she can take her other hand to grab it and bring it back. Okay. Notice Casey's arms are still out like wings. She's not letting her arms touch her scrubs. She's going to open the gown and she's going to slip in one arm, come down to her belly, grab her belly. She's going to slip it in and grab her belly. We see students a lot of times, they put it on, and where do they rest their hand? Way up high, right up to her neck, and that's too close. So just remember, grab your belly because you're going to be feeling sick trying to
Another
get this
thing
down.
I will see students do is they bring the elbows in like this. Well, now I've just, contaminated everything. So they get the gown and then the elbows automatically end up like this. So that, remember, the elbows have to stay out like this. Other things too. Remember, you can't do this. I'll see students go like this and try to grab the gown and slide the gown on like this. See where my arm is up here, right by the neckline? So we don't do that kind of stuff either. We go in one, come down to the belly, go in the other. We also don't do this thing where you're swimming and come in and come down. It's one arm at a time. You're watching it go in, come down.
She turns around and she watches her other arm in, and she comes in, she grabs her belly. Where are her hands?
My fingers never go through the white cuff.
Do I see pink through the cuff? No.
Okay, and then your unsterile person will tie you in the back.
When you're going to tie, you don't want to come up over the front and try and grab way up here. Stay back here in the unsterile and just pull them up over until it's behind. Now I can secure the neck with never having to reach over the front. Right? Then you tie. Find the inside string. You have the piece that's hanging out over here. You don't go after that one. You go after the one on the inside. And just tie this one together.
Casey is far enough back away from her Mayo stand, so now she can kind of come in to put her gloves on. We're looking for how far away are you from that Mayo stand? Is your tie, you're going to be touching that soon. Is it going to be touching that? That would be way too close. And so in lab, we're going to be watching.
Too close.
Yeah, in lab, we're going to be watching that she's back. Now she's bending into her Mayo stand, and that helps keep you away. Her hands are still cupped, and she's going to reach in and she's going to grab her gown. Okay, as she's gloving, her fingers are behind the seam line of that gown. You want to show me your seam line real quick? Yeah, right in there. Okay, so that's where she's going to put her glove. And then she's going to grab, her fingers are still back in the cup. I'm going to watch for pink is what I'm watching to see your fingers coming out the ends. And she'll just flip it over, pull it on. Doing the same thing with the other one. Again, look how close Casey is to the Mayo. She's perfect. She's far enough away. Once you get that second glove, you can just always step way back even. And then you know that you're not going to end up touching your gown or your wrapper. What have we just done on this wrapper? We came in with wet hands. We reached for our towel with our bare hands. Could we have dropped water on our gown? I hope not. There's always a possibility. If you do drip water onto your gown or onto your gloves or anything, now that gown has become contaminated, and we'd have to open a new one. So we've reached over our stereo with bare hands. We've grabbed our towel. We've reached over our Mayo stand with bare hands and grabbed our gown, and then we put on our gloves. And so there's been a lot of things that have happened on this Mayo stand that the potential of contaminating is there. This is why we gown off the Mayo stand, not off the back table.
I see students sometimes when they're coming up here to get the glove, when they have this cuff like this, it'll be really close maybe to the edge. And so here, this cuff is flapping out here like this. See how that would be a problem? Because now that's touching my unsterile Mayo stand. And remember, it's unsterile an inch around the edge as well. So you really got to watch that. So you kind of make sure, you keep them angled in where it's only going to be touching the sterile, to make sure that it's not flapping over the edge like this. You really got to make sure you watch those cuffs when you pick up your gloves too. And you also too, I'll see students also, they're kind of shifting with the gloves, and then this thing ends up happening where I'm shifting, because remember all this down here is unsterile. So if I end up with something like this, and here I am trying to glove, that portion was unsterile. That's where I touched when I opened this gown wrapper. So we really want to make sure you're not shifting. And so if you're really struggling to get your gloves out, you can kind of pick them up a little bit too, take it out and then set it down so that you're not shifting it so much up here on the gown wrapper as well. So remember, once a sterile area has been established, we don't want to change it, because then you're going to have unsterile being brought up to a sterile area.
Okay, so Casey's got her first gloves on then. They're on good. And before she comes and puts her second pair of gloves on there on the back table, she needs to tie with the circulator. So she's going to keep always looking at the sterile field, and the circulator will take that around. She's going to go ahead and hold the short string in her left hand. She's going to hand the circulator, and you can see that the card is separated. We've got this blue right here. This is where the circulator can touch, and this is where Casey's touching. She gets a bigger portion because she's sterile and I'm not. She's going to hang on to that far back away. She's not going to grab it up here and hand it to me, because then look how close I'm going to be.
Way too close.
So she's going to hold it back there. She's going to hand that to the circulator. They're going to take it at that blue area. They're going to come around so she doesn't turn her back to the sterile field. He's going to pull it off, and then they're going to tie.
You sure you're not doing this thing where you reach back here? Wait till they come all the way around. Because can you see back here?
Nope. I can't see behind me.
Let's talk about what happens if it falls off the gown card.
Okay. All right, we're going to do a scenario here for you.
I got you.
Okay.
And this is something that will be practiced in.
Okay, we're going to go ahead and stop there on the video. Does that make sense to everybody? That video, gowning and gloving is super difficult, kind of being taught online. In the lab in September, you will gown and glove yourselves and scrub hundreds of times before you come into the healthcare facilities. That is something that has to be muscle memory and down pat before Mona and Eric will approve you even coming into the healthcare facility. So this video that I just showed you, we normally wouldn't touch this type of lab material until maybe the middle of October, because everything Eric and I are teaching you this summer would be September and the beginning of October. But what's amazing about this program and how it's changed this year is that you all will be doing this maybe the first and second week of this program. So you will have it down pat by the time you come into our healthcare facilities. All right, any other questions? Did that visual kind of help everybody understand gowning, gloving, how to spin?
Yes.
Perfect. All right, let's go back to the test. Okay. So the next one, who places the electrosurgical grounding pad on the patient? That's the circulator. It's a non-sterile item. Who is responsible for assisting the anesthesia provider? And that's the circulator. That again is a non-sterile part of the case. And so as a scrub tech, we normally don't help. Who is responsible for pulling the necessary supplies and instruments for the case? Both. Who gowns and gloves the surgeon? That's your surgical technologist, because they are already sterile. Who drapes the Mayo stand? Surgical technologist. Who arranges the instruments in an orderly, logical progression? And again, that's your surgical technologist. Because all those instruments are sterile, the surgical tech is the only one scrubbed in. So they're the only ones, you know, that won't contaminate the instruments, arranging them on the back table. Who does the initial sponge count? So this was kind of brought up before class started, but you have to have a circulator and a surgical tech to do a sponge count. And it is recorded on a legal document inside the patient's chart. So as a surgical tech, I can't just say, oh, hey, Mary or Kathy, I have 10 Raytex, 2 hypos, 4 swedged, 1 Bovie tip, 1 scratch pad. No, you actually have to count with your circulator, and she has to see each Raytech, each hypo, each swedge, each suture, each Bovie tip. And then if you're doing instruments, she does all the instruments with you, you know, so you'll do 1, 2, 3, 4, 5, 6, 7 scissors, 1, 2, 3, 4 Kellys, 1, 2, 3, 4, 5, 6 Carmalts. So your circulator has to do the initial count with you, and also the next 2 counts, like if you're doing a big belly case. Who performs the scrub prep? So your prep is where they wash the patient. Whatever part of the body it is that you're doing surgery on, whether it be the leg, the belly, the head, the circulator always does the prep unless the surgeon does. Who explains operative phases and answers patients' questions? And that's the circulator. And that's done over in pre-op when the nurse goes over to meet the patient. So they'll go over and say, you know, hey, we're going to take you into the operating room now. And then after the surgery, we'll take you into recovery, pack you, you know, any questions the patient has, they're addressed at that time. Who passes off the suction tubing and electrosurgical cords? So this, again, the surgical tech is the only sterile one out of the 2 team members. So they are the ones that pass off the sterile suction tubing and the Bovie to the circulator, who then plugs it in. Who connects the suction tubing to the vacuum? So the vacuum's a non-sterile item, so it has to be the circulator. Who needs to anticipate the needs of the surgeon? And that's the surgical tech. Who cares for any tissue specimens during surgery? Surgical tech. And again, if you want to go over any of these questions, please feel free.
In these cases,
one was both.
Pardon?
I definitely thought that number 22 would have been both, since the circulator also labels
Okay, tell me what, and I'm just going to play devil's advocate. Tell me what the circulator does to take care of the tissue specimens.
The circulator is the one that gets the specimens handed off to for preparation to the lab, and they label the specimens for the lab.
Perfect. I love it. I'll give it to you.
Okay.
So I will give you surgical tech, I'll give you circulator, and I will give you both. So again, in the email, and anybody who's just logged on, if you have some of these questions on the test that you think are controversial and we go over them in this lecture and I say, absolutely, I'll give you 2 points, send me an email with the question, what answer you picked, and I'll go in and change your grade. So inside the book, and all of these questions are from a test data bank. So they think it's surgical technologist. And the reason that they do is because tissue specimens are passed off to us, right? So let's say the nurse is busy, she's running around doing stuff. We're the ones that are expected to take care of them until it's passed off to her. So we may need to keep it in a wet Raytech. We may need to label it on our back table, but keep it damp until we can pass it off. We just want to make sure it doesn't get thrown away in the trash, which has happened before at all healthcare facilities. You know, you both get busy and pretty soon you're tearing down the case and all the drapes are in the trash. And hey, my nurse is like, hey, where is the disc tissue from the L3, L4 laminectomy that we just did, discectomy we just did? Well, guess what you as a scrub tech get to do? Dig through the trash and try to find that specimen. So kind of a heads up, specimens are a big deal. Make sure you keep track of them. I always try to make it a priority. Hey, can I pass this off to you? I try to get rid of it as soon as possible because it's one less thing I want to worry about during the case. All right, so far I think we have question 5, question 22. Who fills out the operative record? That's the circulator. Who prepares and labels all tissue specimens? And we just barely talked about that, and that's the circulator. Perfect. Who needs to anticipate the needs of the surgical team? So your surgical team is anyone who is sterile. Okay, so that's your surgical technologist, your surgeon. It could be a PA or an NP. It could be an additional surgeon. And so surgical team as a whole, the person who anticipates the needs of that team is the circulator. Who applies the sterile dressing on the patient? Surgical technologist. All right, I'm opening it up. Again, if you guys have any questions, concerns. Who will assist in undraping the patient? And that's both.
Oh.
Who needs to call?
Can you hear me?
Yes. Hey, Ray, how are you?
Hey, I'm doing good. I'm doing good. I did have a question about that one. So in all the reading that I did, it mostly mentioned the surgical tech. And after the test, I was looking through it, and I don't know, I might have to look over it again, but that one was one of them that was it felt kind of tricky to me. I don't know if anyone else felt that way about that one in particular.
Ray, is this 26?
Sorry, 27. One who will assist
27.
in draping the patient.
Perfect. So who will assist in undraping the patient? And you picked surgical tech?
Oh, yes, I did.
I'll give it to you.
All right.
So the surgical tech does a large amount of the undraping because the circulator is usually getting the bed in the room, right? The gurney in the room. They're calling for lifting help. So 95% of the time, it's totally going to be the surgical technologist. Sometimes your circulator does help you, which is great, and it's greatly appreciated. But 95% of the time, it's the surgical tech.
Yeah.
So we have
and kind of from what I've understood about the overall reading is like, you know, the surgical tech does everything within the sterile field, and then the circulator is kind of going around, like, you know, not the
Yes.
outskirts, but you know, and to me, it's just kind of
Absolutely.
it. If you have the patient draped, the most appropriate person would be the person that's kind of in the thick of it, not in the outside. But you know, that's why
Correct.
I picked that. Yeah.
Yeah, that's perfect. And another thing is, when we're undraping the patient, we still have on our gown and gloves. So if those
Exactly.
drapes are bloody, have pieces of bone in them, have pieces of bowel, pieces of fat, piece of adipose tissue, we're still protected because we still have on our surgical gown, right? And our eyewear and our gloves. 99% of the time, circulators don't put on gowns. And so we have one trauma nurse that does, and she's like, I've learned my lesson. I am not getting blood, bowel contents, fat, bone on my scrubs, right? So that's another reason that surgical tech truly is the majority of the answer, because we're still covered and all those drapes will have body fluids and tissue all over them. So
Yeah, that makes sense. All right, cool. Thank you.
hey, you bet. All right, number 28. Who needs to call for lifting help? And that's the circulator. And that's because she's not sterile.
Sorry, Angela.
Who's responsible?
I have a question about 28. So
You bet.
I answer both because I understood that in post-operative phase, the circulator call for lifting help. So I think that I call surgical tech to help them to move the patient. Is wrong?
So the surgical tech definitely helps to move the patient, but a large amount of the time they won't call for lifting help because they'll be cleaning up their back table and cleaning up the patient.
And who the circulation call for lifting help?
Yeah, no, that's a great question. So inside of so in labor and delivery, you only have one operating room, right?
Yes.
So upstairs in the main OR at St. Al's, and tonight you'll see it at St. Luke's Meridian. At St. Al's on the second floor, we have 18 operating rooms. And so with those operating rooms, we have, I think, 8 ORAs. So it's operating room assistants, and they're the ones that pick our case carts. They help us move the patients. They clean our rooms. They run for blood, any of that type of stuff. I think at St. Luke's, maybe they're called orderlies. So lots of times we may have big patients. And so the circulator, it's usually the circulator, an ORA, maybe a PA, and maybe the scrub tech, if they're needed, will help move the patient. So they are calling for those ORAs, any extra staffing that's available, anybody that's available for help. And usually you only need 3 people to help move the patient. But if you don't have those 3 people, someone's back is going to get hurt. So if it's only the circulator and the scrub tech, that's 2, and you always need a 3rd person. And the CRNA gets moves the head. So a total of 4, I guess.
So in this case,
Does that make sense?
The circulator
Go
is
ahead.
the only right answer, right?
Yes, ma'am.
Okay.
And it's simply because the surgical tech is usually doing, cleaning the patient, cleaning the instruments, cleaning up the back table, all of that type of stuff.
Okay.
Who is responsible for maintaining the sterile field until the patient leaves the OR? And that's the scrub tech. And that's simply because the circulator at this point is taking care of the patient. So she is getting her chart finalized. She is making sure that the patient is breathing. Lots of times in the OR, if you have like young male teenagers, maybe in their late teens or early 20s, they can wake up pretty violent, and they wake up screaming, flailing their arms, kicking. And so it's super important for the circulator to be right next to the gurney after the patient has moved on to the gurney. They can fall off the gurney. They can, try to get out of the gurney. You may have elderly patients with dementia that will behave the exact same way. Who assists the anesthesia provider with transfer of the patient to recovery? And that's always the circulator. Who is responsible for disposing of any soiled sponges, sharps, or patient-contaminated items? And this answer is surgical technologist. Who watches for breaks in aseptic technique? And that's the circulator and the scrub tech. Who prepares the room for the next case? That's both. Both of you will be opening instruments. Go ahead.
Yeah, for the last two that we were just going over, so from what I understood, number 5 basically not contradicts, but I don't know, that's what kind of confused me, that I got both of them wrong. And I'm just like, well, I thought that the main thing was the surgical tech watches to make sure there aren't any breaks, but then it's saying, oh, both of them watch for breaks in aseptic technique. I don't know. For question 32, I put surgical technologist. Yeah, that's what I put. Yeah. So
yes. And that's what I thought too. I'm like 5 and 32 are so close.
Yeah.
You know, in what they're asking. So I'll take surgical tech on 32, because that's truly the surgical tech. They are in charge of aseptic technique, right? Like making sure that there's no contamination, et cetera, et cetera. Your circulator also watches for that. So let's say that the scrub tech hit the top of their hat on top of a light handle, but didn't feel it. Like you may just barely brush the top of a light handle with your scrub hat. The circulator will be able to see that and catch it. So that's where it kind of comes back to both. But at the same time, it is the primary responsibility of the scrub tech to watch over their back table, their Mayo stand, once the patient is draped. So 32, I will take answer A or answer C.
Okay. And then also on question number 33, my understanding was, just like you just barely mentioned, that usually, you know, once the case is done, the circulator's main concern is getting them to the PACU, getting the patient to the PACU. So, I mean, I get why it says both prepare the room for the next surgical case, but at the same time, I'm like, okay, so I thought the circulator did this particularly right after the surgery. I understand they can come back, but you see kind of how that's contradictory?
Yeah, I do. Yeah, so let me explain the process really fast.
Okay, yeah.
Because at a certain point, neither of you are in the room.
Yeah.
So the circulator takes the patient to recovery, and then you as a scrub tech will actually take your surgical cart around to dirty holding. You'll throw away the linen, you'll put the linen in the linen container, throw away the trash, and send that case card to SPD. During that time, usually your orderlies or ORAs are cleaning the room, and you both kind of make it back to the room almost at the exact same time.
Okay.
And then you prepare for the next case. You know, so I bring my case card in the room. She grabs the preference card and starts looking for local or medications, checks to see if radiology needs to be called, you know, all of that type of stuff. So truly it's both. It takes both people to get the room ready.
Okay.
Does that make sense?
I get it. Yeah, that makes sense.
Yeah, because if I was the only one doing it, I would miss all of her preparation stuff. So I wouldn't be able to pull the local, I wouldn't be able to call radiology, I wouldn't be able to pull the necessary positioning aids. So your circulator really does all of that stuff, while you as a scrub tech focuses on instruments, suture, gloves, all of that type of material.
Mm-hmm.
Does that make sense, Ray? Sorry.
Yeah, no, it's okay. Makes sense.
All right, 34. The goal of the perioperative phase is to provide optimal patient care before, during, and after a surgical procedure. So remember, your perioperative embraces all three of those: your pre-op, your intra-op, and your post-op. Which of the following is not one of the 8 principles of economy of motion to follow when setting up the back table and Mayo stand? And the answer is move about as much as possible. So the hard part is you want to try to stay within like a foot to 18-inch radius when you're setting up your back table. And that's to minimize contamination. The more that you move, the higher likelihood of you contaminating your back table. 36, the goal of the preoperative phase is to prepare the patient psychologically and physiologically for a surgical procedure. The goal of the intraoperative phase is to provide safe administration of anesthesia, to promote the principles of asepsis, to maintain homeostasis, and to control blood loss. A nurse who helped found the field of perioperative nursing during the Crimean War was Florence Nightingale. The pre-incision timeout should be performed by which members of the perioperative team? And that's all. Every single person in the operating room should be participating in this timeout. And as you get into the operating rooms, when the timeout is being said, there is no talking, there is no movement. We are all entirely focused on that timeout. Wrong site surgical errors can result from failure to perform the timeout before surgery. And I will tell you, wrong site surgical errors have happened at every single healthcare facility in the Treasure Valley. You may not have heard about it, but I know that there has been a wrong side shoulder surgery done at St. Luke's. I know at St. Al's there's been a wrong side knee surgery done. So it's super important that you as a scrub tech is also kind of aware of what is on the consent as well as what's being said during the timeout. Approximately what percentage of serious medical errors are thought to be associated with miscommunication during patient handoffs? And that's 80%. You as a scrub tech, if you want to be respected in the field, give a good handoff to your coworkers. So if they come in to give you a break or a lunch, hey, just kind of a heads up. And this is what I would say to them. This is where we're at in the surgery. This is what he said he wants next. My circulator is getting this suture. I have such and such a specimen on the back table. These are the next sutures he's going to be using. And quickly go over your medications on the back table. Hey, I have 1/4% Marcaine with Epi, and saline is inside my pitcher. That will prevent your coworkers hating you because you left them high and dry and the surgeon screamed at them during that half an hour or 15-minute break. So surgeons love continuity, right? They don't want any issues during the case. They don't want any confusion, et cetera, et cetera. In ortho cases, hey, we're using a 4.5 cannulated screw on this particular surgery. Give your coworker that type of heads up. Don't take 5 minutes to explain it because everybody is short-staffed. Give them like a 2-minute handoff. This is what we're doing. This is what you'll need. This is what he's thinking he wants to do. These are my medications on the back table. Does that make sense to everybody?
Can I just say, at my job, I hate it when people don't give complete reports. Like, we'll have someone that fell down and they won't tell us, and I'm just like, okay, why didn't you guys tell us? Why didn't you guys tell us that we need to make sure that we're checking in on him more often? You know, it's
yeah, that he's a fall risk, right?
Yeah, he's a fall risk. You know, let us know that it happened. Let us know he's probably more confused. He's probably more agitated. You know, yeah, no, sorry, that's a big pet peeve of mine too.
Yes, super frustrated. I hear you. You know, because they'll come. You know, because I give breaks and lunches, you know, et cetera. And the doctor's like, what do you mean? I asked for this 10 minutes ago. And I was like, well, 10 minutes ago, I wasn't in here. And the person I relieved didn't tell me anything about it. But make sure you follow up with those coworkers in a nice communication way and just go, hey, by the way, next time I give you a break or a lunch, will you just, I mean, this is what I say. Will you let me know if he's asked for something before I got in here? You know, and then they're like, oh yeah, I'm so sorry, you know, I'm so sorry. But you're like, I'm not the one, you know, or you're not the one that just got yelled at by Dr. Hajar or whoever, you know. So no, I totally relate, Ray. It is tough.
Oh yeah, and that's why I always try to give a super complete report. Like, I'll even take extra time and explain how the whole day went with one particular person if they're having a particular tough time. And just no, I want you guys to know, you know, what's going on with them. Because that's it. I don't know. Sorry.
Yeah,
I'm on a little tangent.
It's important. No, that's great. It's important information, and it makes just a better patient care environment for everybody involved.
Exactly. All right, cool.
Awesome. Yeah, thanks for contributing. I appreciate it. All right, an instrument falls below the level of the back table during an operative procedure. Only the circulating RN sees this happen. What should happen here? The nurse should discard and replace the instrument with a sterile one. All right, name 2 identifying factors in establishing patient identity, patient name and date of birth. Who is responsible for marking the surgical site? And that's the surgeon. No one else in our team can do it. I have seen nurse practitioners and PAs do it, but ultimately it is the surgeon's responsibility. According to the World Health Organization and Joint Commission, the following information should be included in a preoperative checklist. And that's a signed consent, a patient identification, and a marked surgical site. All 3 of those have to be done before the patient is even brought to the OR. So in pre-op, the surgery will come to a halt if all 3 of those things are not done. All right, 46. We had quite a few people miss this question. According to the Joint Commission, what is a timeout? Take a guess what a large amount of our class picked.
Number C.
I know
C.
I picked C. Yeah. That's what I picked.
Okay.
Can I say something
All right.
about the letter C, Angel?
Absolutely.
Yes, I chose a C because I understood that during the timeout we talk about the right procedure, but also the right date of patient. For example, if for the lesion the patient doesn't accept the blood, or for any type of reason they refuse transfusion or something else.
Correct. So you do. So, okay. That's perfect, Alessandra. I love hearing your reasoning, and how you're processing it. So I'm just going to ask this question. How many of you go through hold on one sec. Okay, does everybody see the week 5 module layout?
Not yet.
No? Oh, why is that not converting? How about now?
Now, yes.
There we go.
Yep, it's there.
Perfect. Okay, how many of you print off these AORN study guides and read them?
I did. Yeah.
Yes.
Perfect. Okay, so let me show you something. This is the 3rd to the last page on preparing for surgery, a patient's perspective. Guess what question 8 is? According to the Joint Commission, what is a timeout? And guess what? What are those?
I can't see anything, but I'm guessing it says the answer,
hold on.
important information, right? I'm guessing.
All right, hold on.
All right. I'm guessing it's going to say a review of all the important data relating to the procedure.
Okay.
Makes sense.
Oh, can you see number 9?
You mean number 8?
Number 8, I'm sorry.
Yeah, no,
Yeah.
it's all good.
So this was at the very end of one of your AORN packets. all of these questions. And look what else is here. Those are the answers. So everybody had these questions and answers prior to the test. So as much as I want to give you 2 points, everybody had this material. Did you guys realize that?
Yes, but my point is, it's not true that we talk about just a procedure during the time off. We talk also the right page of the patient, I think.
Correct. So during a timeout, what do? We do a review of all important data relating to the procedure. So what is that? That's the right patient. It's the right procedure.
Is include all inside of the right procedure?
Yeah, absolutely. It includes everything. So I'm going to go, hey, here's a normal timeout for us. This is Mary Smith. She is here for a right hip arthroplasty. We have x-ray in the room. We introduced everybody. This is Carrie, the x-ray tech. This is John. He's the CRNA. Kelly is our nurse today. Angel is the scrub tech. We're going to be going ahead and be sending bone specimen because we think that there's a possible infection in there. If there's an infection, we're not going to be sending any sort of specimen, or I'm sorry, if there's an infection, we won't be using any implants today. We are going to be go ahead and using cement. We might be doing antibiotic spacers if there is infection. Does anybody else have any questions or concerns before we get started? That's a timeout. So you don't just cover the right patient and the right procedure. Does that make sense?
Yes.
Okay. So your timeout can be a very lengthy, 2 to 3 minutes ordeal because you want to make sure and get any issues that may occur during the case out of the way. So, do we have x-ray in the room? Is pathology available? So you talk about all that stuff during the timeout. It's way more than the right patient and right procedure, okay?
Yes.
So just a heads up for your guys' next test, there is an AORN video that you're supposed to watch. I guarantee you the questions at the very end of that AORN study packet, some of them will be on the test, and you have the answers. And those answers follow that AORN video. All right, number 47, assessment data are collected, and the answer is all of the above. Assessment data may be collected from, and the answer is all of the above. Surgical sites should be marked pre-operatively, and it's when the surgery involves limbs, when the surgery involves bilateral organs, so such as kidneys, breasts, when the surgery involves multiple structures or levels, and that has to do with usually your neck and your back. So hey, we are doing thoracic levels 2 to thoracic level 12. And that big of a surgery might be being done because they have a fracture from a car accident. So you're going to put in rods and screws, do a slight decompression. But you really need to make sure that it is marked, that part of the back. They obviously won't mark the neck. They won't mark the cervical region. They won't mark the lumbar region, but it'll be the thoracic region, middle of the back. Data about alcohol intake and recreational drug use are essential. Does anybody know why that's so important in the healthcare field or even in the operating area?
You wouldn't want any contraindications to any medication used during surgery.
Perfect. What else? Anybody have any ideas?
Sorry, could you repeat the question again?
Yeah, why is it so important for patients to be honest about their alcohol intake and their recreational drug use?
Well, I know, for example, I don't know if someone mentioned this already, but it can amplify the effects of painkillers, narcotics, probably give them, you know, definitely stop breathing. For example, I know that's one of the consequences of opioid overdose, right? They stop breathing because, you know, their body basically relaxes to the point where their body says, "Oh, I don't have to work too hard to breathe," and then they stop breathing. You know,
Perfect.
there's other stuff I'm sure, but
Yeah, and also those patients that use a large amount of alcohol and recreational drugs, they burn through anesthesia and their pain tolerance isn't as high as someone who may not be an alcoholic or be a recreational drug user. And so it really helps anesthesia and the surgeon and even the post-op know ahead of time, hey, this person, you know, takes, I don't know, 10 oxycodone a day, or they drink 3 24-packs a night. That's going to kind of let them know, hey, this person's going to burn through anesthesia. Normal painkillers may not work, so we may want to do a block on them to provide pain relief. You may want to do a consult with pain management team. So, and you'll find out even some recreational drugs cause blood to thin, and so the clotting factors won't be there. And if you're doing, you know, some sort of vascular case and you can't figure out why the patient is bleeding so much and why they're not clotting, sometimes post-operatively they come back and go, oh yeah, this patient is a such and such user, you know, or they may even be taking, I know St. John's is some sort of natural supplement, I think is also a blood thinner. And so that's also very important to share preoperatively. Oh yeah, hey, I take these natural supplements because they may cause physiological reactions within the body. Does that make sense to everybody?
yeah, that makes sense.
And so,
Okay. All right.
do we discuss about that during the timeout? Because everybody knows before the surgery.
Yes.
Okay.
Absolutely. That can be shared during the timeout as well. The surgeon may say, hey, and the CRNA and anesthesiologist have already had access to his H&P, right? So his history and physical. So they may know already, hey, just a heads up, you know, this guy's a heavy drug user or he's a heavy drinker. If you're working near the liver, you may see cirrhosis of the liver. You know, it may tend to bleed more, or they may have a fatty liver. But that can definitely be discussed in the timeout.
Although I'm sure you've
All
seen
right.
before that some people like live really, really double lives. You know what I mean? So, I mean, someone could. I'm just being serious. Like, you know, there are some people that you know go on cocaine binges every day, but
Yeah.
you know, have a steady 9 to 5 and all that.
Absolutely. And it is incredible how many people can be functional, living so-called normal lives, and be heavy drinkers or heavy drug users, you know, and you would honestly have no idea. And so sometimes it's really hard in the operating room because you're like, why is this patient bleeding, or why are they burning through so much anesthesia? You know, and maybe they do a UA or something like that and go, wow. Or maybe a family member then comes back and says, hey, just kind of a heads up, you know, they consume 3 or 4 bottles of vodka or rum every single night. So that's, yeah, great addition, Ray, because that is so true. You just never know who is a heavy drug user and who's a heavy drinker.
Yeah, you really know. So I used to work for this pizza delivery company that for now shall remain unnamed. And if anyone says anything, I'll kind of deny it. But I know the tippy top of our franchise. Yeah, that's all I'm gonna say.
All right.
Oh, it's crazy. It's crazy. All right, go ahead. Sorry, taking too much.
No, you're all good. All right. So I put this announcement, so we're going to jump to this next section, this next material. A couple things. Number one, and Carly, don't worry about doing this. I've already graded your PowerPoint. Everyone else who has not turned in their PowerPoint, please email it to me instead. And as a class, would you be interested in your classmates sharing their PowerPoints or their PowerPoints being shared like in a class folder so that you all get to know each other a little better? I'll do whatever majority says, yes or no. Mona thought that would be a great idea. Because again, you guys are in this program for the next 9 months. You're gonna ride some serious roller coasters, and sometimes your classmates become your best friends and become your, your sounding board. They kind of pick you up when you've had a rough day because they understand what it's like when you've had a rough day. But if anybody would be interested in that, we do share a slight, what do I want to say? Kind of like about you page at all the healthcare facilities with a picture, and that's simply so the staff can get to know you and go, oh yeah, like that's Haley, or that's, whoever it is. And so they'll know a little bit about you prior to you coming into the healthcare facility. But anyways, Simona said, hey, ask them if they'd be willing to share their PowerPoints with each other, just so that they get to know each other on a little bit more of a personal level before we hit the ground running in September. So if you do have a problem with it and you don't want to post it on here, please feel free to email me, okay? So email me your PowerPoints. Next thing. Next week, we have a discussion board, and next week's lecture is all about legal and ethics. So I'm going to quickly go to next week's module, and I just want to quickly show you okay. So we divided into 4 groups. So what you'll do for next week after reading through the material, all the material, do not answer or post anything on the discussion board until you have read all the material and gone through it, okay? So here's your groups. So let's say, I'm just going to pick someone. Jessica Scott. My name's Jessica Scott. I'm going to go down to forum group 4. I'm going to create a thread. You have to click create a thread before you see the material. Does that make sense? And then you're going to read through this case study. And then subject, I'll put group 4 or case study. And then down in this section is where you will answer the questions, okay? I want well thought out responses, not, so your first question is, was this a civil or criminal wrong on the part of Dr. Favara, and why? It was criminal because he was a bad surgeon. Not those type of answers. You will get a big old 0. Okay, so I want you to really think through what your response is going to be. Use the material that you just read and incorporate some of those words. So what you have to do is you have to make a primary response. So you're going to answer all those questions. And then I want you to respond to 2 of your classmates. Okay, so a total of 3 responses. But again, you have to click create thread to be able to see the material. So each discussion post should consist of complete sentences and appropriately answer the questions. We advise, I always do this with anytime I'm doing a discussion board, put your reply in a Word document. and then copy and paste it over, and it'll help with grammar and spelling errors. Each post should consist of your own words and thoughts. If you choose to add research material to your post, it must be cited and referenced correctly. Failure to do so is plagiarism and grounds for withdrawal from the program. Any post that does not meet the word count minimum, the due date, and is not cited and referenced correctly will not receive the credit. So each discussion assignment will consist of 3 posts. Initial post must answer all questions at the end of the case study. Post your original thoughts and opinions. Do not go on and Google it and copy and paste it. You will not see the others' post until you post your initial reply. And then 2 posts to other students. Those posts must be at least 100 words. You cannot use the same post more than once, so do not copy and paste the same response on Ray's initial post and then do the same thing on Carly's. Absolutely not. Each post must be different. If you choose to add material provided by website or book to your post, it must be cited, et cetera, et cetera, et cetera. So obviously, big thing is plagiarism in college courses. Okay, does everybody kind of understand that? And that is due, I believe, the same day as your test. Okay, so you'll have all week to write your initial response and then do the 2 additionals. All right, so let's take a 5-minute break. We'll be back here at 10:25, and then we will start the material for this week.
Angel, sorry, can you repeat me the due date for the presentation and for this, the other task, please?
You bet. So your PowerPoint presentation is due on July 18th.
Okay.
And Alessandra, I want you to email it to me as an attachment. So
No, I think that I would like to share my information.
Perfect. So
Yeah.
go ahead and email it to me, and then we're going to create a class folder and put everybody's PowerPoints in there.
Okay.
Does that make sense?
Mhm.
But for some reason, Blackboard is kind of having a hard time, what do I want to say, with downloading the PowerPoint presentations if you submit it through the homework area. So just email me your PowerPoint presentations, okay?
Okay. And the other
The
due date
second,
for, yes.
go ahead.
No, the other due date for that presentation, the group project.
So the discussion board will be
Yes.
due on July 25th by midnight.
Okay.
All right?
Thank you.
You bet. Great question, Alessandra. It's supposed to be the surgeon. Sometimes nurses will do it.
Mhm.
However, the surgeon is supposed to initiate it. And then at that time, after he or she is done with whatever they are saying, then the scrub tech or the circulator can kind of pipe in and say, hey, are you going to be normal? Our questions are normally, do you need x-ray?
Okay.
If it's a procedure that we think might need x-ray, are you going to be sending a specimen? Do you know what you're going to call that specimen? And that gives the circulator time to start the pathology paperwork, right?
Mhm.
Are you going to, do you know what type of dressings you want? Any kind of questions where we can kind of anticipate and prevent delays in the procedure. Do you want a pain pump? Do you want a pain ball? Are you going to want a brace for this patient? Is this patient going to ICU post-op? So all that information you try to quickly cover at the end of whatever the surgeon said during the timeout.
Okay.
And honestly, the surgeons really appreciate that because it prevents their cases from being delayed. It creates a quicker turnover, everything else like that. So does that kind of answer your question?
Mhm. Yes. Thank you.
Perfect. Hey, Carly, I don't need you to email yours. I think I'll be fine figuring out how to put it in the student folder, but I'll let you know otherwise. But yours is already graded. I just haven't put the grade inside the grade book yet, inside the grade center.
Okay, thank you.
Yeah, but I'll be in touch if we struggle to get it downloaded. All right, PowerPoint presentation. Everyone should be back from their break by now. Perfect. Okay. So this week's material is all on communication, interpersonal relationships, and communication skills. Communication is huge in the operating room. And although you may have a case where there's minimal talking, there is still a ton of nonverbal communication that exists in the operating room. And you become really, what do I want to say? You become an expert communicating with your eyes. I can't explain it, but because your mouth is covered, you and that circulator, you kind of create, what do I want to say, like a communication area or expertise, kind of with your eyes, with your hands, etc. Your coworkers will come in and ask you if you want a break or a lunch without talking. So, there's definitely hand symbols. Your surgeon uses hand symbols to ask for tissue forceps, scissors, Kelly's, Carmalt, Bovie, and you guys will learn all of this type of stuff, but a ton of nonverbal communication exists in the OR. So our module objective, after completing this module, we'll be able to apply effective interpersonal relationship and communication skills as they relate to surgical technology. Terms and definitions that we're going to cover: behavior, chronic, cliche, communication, confidentiality, conflict, conflict management, ethical, hierarchy, need, peer, protocol, self-esteem, self-image, and therapeutic. All right, so this covers the type of relationships. Social, so we have between peers, okay? And this is one that belongs to the same group in society, primarily determined by age, grade, or status. So we're all peers, you're all peers in this classroom. Have a mutual relationship. It's not goal-directed. Remember this, put a star by this. Social relationships are not goal-directed. Maybe casual or intimate, brief or long-lasting. Behavior limited by social protocol, but feelings, ideas, and actions are shared. So the word behavior, observable response of an individual to the environment. And then what's a protocol? To adhere to the appropriate manners and behavior within a given situation. So if you have a patient that is crashing in the ER, there may be a protocol to quickly get the crash cart in the room, to get blood bank on board because they might need a massive transfusion. Next type of relationship is professional, and that's between coworkers of a profession, not a mutual relationship. And this is goal directed. You and your circulator have a goal to take care of this patient the best that you possibly can. Or if you have an extremely critical patient, your goal may be to get the patient off the OR table and up to the ICU before they pass away so that the family members have a time to say goodbye to them. It is limited to the conduct under job description. Behavior is guided by ethical code and policies of institution. And in this material, ethical means adhering to accepted principles of right and wrong that govern the conduct of a profession. Our next type of relationship is therapeutic. It can be between a healthcare team, the patient, and the patient's family. This is not a mutual relationship. It is goal directed, and that very well could be, if they're on the rehab unit, it could be between the physical therapist, the patient, and the patient's family, and maybe their goal is to get the patient walking or bathing themselves before they're discharged. It involves the care and treatment of the patient. Relationship lasts duration of the patient's service. After the patient is discharged, usually that relationship no longer exists. The patient's trust and confidentiality must be respected. If we lose the patient's confidentiality, or if we break the patient's confidentiality, we lose their trust, okay? So keeping information given to you in confidence, secret of a profession. So I wanted to show you this surgical technologist. Here's a good visual aid. 3 different types of relationships: social, professional, and therapeutic, okay? Do you guys ever want me to post my PowerPoint presentations?
Sure, I'd like that.
Yeah. Okay. All right. So, whoa, I don't know what I just did there. Sorry. Objective 3, factors needed for a good relationships. So effective communication. Sorry, hold on. I just kind of clicked over. There we go. Recognizing and meeting your needs. Recognizing and meeting other person's needs. So in any social relationship, etc., there are givers and takers. And then I think in every relationship, we're probably givers and takers, but finding that good balance, right? Making sure that your needs are met and the other person's needs are met. Behaving in the correct manner at the correct times by recognizing the type of relationship that exists. Make sure that when you're in the hospital that, how do I want to say it? Some surgeons can be inappropriate. Do not fall into that trap, okay? Keep your relationships professional, and understand that it is a working relationship, okay? Does that make sense? And unfortunately, as much as we want to say that the ORs are a professional environment, it can be a pretty unprofessional environment. There's swear words, sometimes inappropriate jokes are told, and you don't need to be a part of that. Especially while you're a student, please do not be a part of that. All right, so I kind of covered that part. Maslow's hierarchy of human needs. We're gonna hit this one more time. Psychologist Abraham Maslow, identified the following as needs common to all. Based on a hierarchy of priority, the lower needs must be met before an individual can move on to the next level. So what are your needs? Physiological or psychological requirement for the well-being of an organism. What's a hierarchy? People or things organized or classified by rank. And unfortunately, we kind of see that a lot in the OR, is that there's definitely a hierarchy, right? So your surgeon, your CRNA, you and your circulator, unfortunately, it just kind of exists. But remember, you all work together as a team. So your housekeeping, your orderlies, they are worth their weight in gold, and they bust their heinies for you. So make sure that you're treating them with the same respect and decency that you would treat the CEOs of the hospital. Physiological, most basic and dominant. So it includes the need for food, fluid, oxygen, temperature regulation, physical activity, rest, elimination, and sexual satisfaction. Security includes feeling safe, emotionally secure, and comfortable. Social includes affection, love, acceptance, kindness, belonging, intimacy, and friendship. Ego, and you will see a lot of egos in the operating room, includes approval, recognition, prestige, and status from others because of an individual's actions, elevates the self-esteem, and self-esteem is one of our words, confidence and satisfaction in oneself, and self-image, that's the mental concept one has of oneself, okay? And then self-actualization, the ultimate in personal achievement in reaching goals of direction, identity, realization, and fulfillment. Here's a diagram of Maslow's hierarchy. So remember, you have to have your physiological needs met before you can move on to the next level, right? You also have to have your needs met before you can start to take care of someone else. All right, objective 5 is stress, and we've talked about stress in the past, eustress, distress. There's a good type of stress and there's a negative type of stress. Probably for your first year, especially while you're in school, you will feel a lot of stress. Going into the operating rooms and the healthcare facilities will cause a lot of stress. Just make sure that you have proper coping mechanisms when you're doing this. Make sure you have good shoes. You know, your back can hurt. As much as we all want to be in style and in fashion, in our work environment, your back, your knees, your legs will take a beating if you don't have good shoes. So stressor in the operating room, these can include general surgical environment, okay? It may be extremely hot. Team member personalities. So you may have a circulator or a surgeon who maybe isn't the nicest individual or doesn't treat you very nice, or a surgeon who's very demanding. You're going to have emergency situations. Everybody in their healthcare field has experienced it. Even in a day surgery, we like to call them a day spa, where, you know, they usually work Monday through Thursday, 7 to 3. There's no weekends, no holidays, no call. Somewhere along the line, you're going to have a patient code. So everyone will have emergency situations. Unfamiliar procedures, and we all kind of get put in those surgeries where we've never done them before, or we've done one maybe 10 years ago. So that's another cause of stress. Malfunctioning equipment. Maybe you have a stapler that's not working. Maybe a screen. I was in on a surgery yesterday where both of our screens went down in the operating room and we were doing a laparoscopic procedure. Incorrect or insufficient supplies and tools. I will tell you, when COVID hit, there was a national backorder on the craziest things. We couldn't get IV fluids, and so we had to find a different distributor for our IV fluids. Sometimes right now at St. Al's, we're out of shoe covers, and we've been out of shoe covers for 9 months. So when I brought you to St. Al's, I actually bought those shoe covers off of Amazon, which I use them because I don't like getting blood and bowel contents on my shoes. I'm trying to think what else. We sometimes run out of staplers. Right now we're out of a couple of the bowel staplers. If a hurricane hit, I think there was a hurricane that hit maybe 3 or 4 years ago in the Dominican Republic, and that caused national back orders on items. So just kind of in your mind, know what maybe is on national back order. Don't open it unless it's really needed, or have some sort of substitute in the room. A breach in aseptic technique. this can be massive, massive stressor. We dealt with this yesterday. We had a room open for a procedure. The scrub tech scrubbed in. She set up the whole entire case. She went to pick up, I think it was a kerosene, and there was a piece of bone stuck in the kerosene from a prior patient's procedure that got missed in sterile processing department. Patient was already in the room. They were already intubated, and we had to tear down the whole entire room, reset up. So you have to call your SPD, they have to send up another case cart, get the back table open, reset up the whole entire case. That can actually happen quite often. You may have a set that wasn't sterilized properly or doesn't have the little tab in it saying that a certain temperature was reached. And that can be a pretty stressful event. Your surgeon can be in there yelling, why aren't we going? What's the problem? What's the holdup? Situations involving moral, ethical, and legal dilemmas or challenges, depending upon how you stand on certain things in your life or what your beliefs are, what your morals are. Sometimes those can be challenged in the operating room. The physical wear and tear that stress causes: high blood pressure, a headache, a loss of appetite, increased appetite, weakened immune system, heart failure. There was a kind of a joke going around when COVID was going on, but it was like, I don't know if I have COVID, or is my ponytail pulled too tight? Am I dehydrated, or am I just having an anxiety attack, right? Because maybe you had a headache, but maybe your chest also felt tight. And it kind of goes that way in the operating room. You know, is your hair, you know, too tight in a ponytail? Have you not drank enough water? Are you having, you know, stress which is causing anxiety? So you kind of really have to differentiate how your body is responding to that stress. Coping methods to deal with stress include exercising, imagery, deep breathing, muscle relaxation, getting enough sleep. That is huge. Sometimes you have to make fairly quick decisions in the operating room. And if you haven't had enough sleep, you're going to be delayed in making those decisions, or you may make wrong decisions. Humor, positive reflection on your day's events. You had a really rough day. However, what did I learn today? What can I take away from it? Eating healthy, regular meals. You don't want to eat some greasy hamburger or burrito before you go in to do some 8-hour case. Caring for your physical and emotional needs. Okay, make sure that you have a sounding board or that you have a way to release that stress. Dealing with sources of conflict. And there is definitely sources of conflict in the operating room. You know, maybe with your own staff. Just make sure that those are dealt with appropriately and that patient safety isn't inhibited by those. All right, objective 6, psychosocial stress in the patient and within the surgical team. So how do our patients react to fears and anxiety? And trust me, you will see it in so many different ways. Resentment and hatred toward the healthcare team. Here, I've heard this one before. What's taking so long? Were you guys eating lunch? Did you have a long lunch break? Or what were you doing? And actually, no, we'd already done 7 cases before this patient's procedure. Changes from normal speaking patterns. They may be a normally introverted person, but once they've had a little bit of medication, or maybe they're having some stress or anxiety, nervousness before the procedure, they may turn into an extremely talkative person. Physical changes, so higher blood pressure, higher heartbeat. Stress may be acute among children as they lack understanding of the surgical environment, especially your young kids that don't understand why they're being taken away from their parents. Why are they being taken into this room? They can't see your smile, you know, they can only see your eyes. They're afraid of injections and pain. They have a strong fear of anesthesia, right? Kind of the unknown. And we talked about this a few weeks ago, and I don't remember who shared it, but you know, hey, you're going to go to sleep, and maybe they had seen the family dog be euthanized due to old age, and so they think they're going to sleep and won't wake up. They can experience separation anxiety. Elderly patients can experience many symptoms and may need extra care and patience. I think we've mentioned this before, you know, holding their hand, patting their hand while they're going to sleep makes a huge difference in these people's lives at that particular moment. They won't remember it when they wake up, but that particular moment is huge, you being able to provide that compassion. The surgical team should look for these signs and act to calm the patient. Responses depend upon the patient, but should include allowing the patient to verbalize and explore their fears and grief. Don't ever try to shut a patient down. Frank discussion of the surgical technique. Hey, how are you going to take out my gallbladder? Or we're going to make, you know, 4 teeny tiny incisions and dissect out the cystic, you know, clamp off the cystic duct, cystic artery, and take it out through one of the bigger incisions. Helping the patient with the relaxation techniques, right? So deep breathing. Go ahead and take some deep breaths. Think of happy thoughts. We always tell our patients, think of a beach or think of skiing, whatever you like to do. And a simple comforting touch, which I already kind of mentioned. Truly that hand holding can provide incredible relaxation. Maintaining a quiet, unhurried surgical environment. At times in our career, this can be, it can seem impossible, especially if you're doing like an orthopedic case, a total knee, or maybe a back fusion. You have a rep in there who's explaining, this is what we're going to need, these are the handles we're going to use, this is the drills we're going to use. He'll probably use these type of screws. You know, it'll probably be a 24 bar. You're going to want the end caps. So he's going to be telling you all of this material, but at the same time, you have to be respectful and quiet because that patient is going to sleep. So I will tell you, lots of times in my career, I have put making a quiet, unhurried surgical environment as last on my list. And then something happens and you get reminded, hey, I need to make sure that I'm doing my part to make it a quiet and unhurried environment for this patient. And it's hard because unhurried doesn't exist in our profession. You are always hurrying. So just remember that, you know, if you were on the table, you wouldn't want a loud environment as you were going to sleep. Noting the patient's need for physical comfort. Discussions with members of the patient's family or other support team. Among the surgical team, stress is an inherent part of the job. Harsh criticism directed at a member of the surgical team may be a surgeon's method of coping with particularly difficult situations and should not be taken personally. And I don't know if you all remember during, I believe this was one of our interview questions, and kind of how you handle conflict, that type of stuff. Every single one of you will experience a surgeon being rude, disrespectful, and unprofessional, and 99.9% of the time, it's because they are having massive amounts of stress about the patient and how the procedure is going. So again, don't take it personally. It's not you, it's the environment, and it's how the procedure is going. Objective 7, goals of communication. To provide information to others, to obtain information from others, to express feelings, to solve problems through communication, to persuade others to change an attitude or a behavior, to prevent error in the OR, and to promote patient safety. So objective 8, means of communication. So we have verbal, which can be given by oral, written. We have nonverbal communication. Hold on one sec. I just want to make sure I got. Okay. Objective 9, purposes of communication among hospital team members. To maintain accurate records, So we want to make sure, especially where you're doing surgeries with implants, you want to make sure that your rep, so your implant rep and your circulator, know the exact size and length of the screws. So, hey, we use 7.5 45 millimeter cannulated screws times 5. We used a 35 bar, all that type of stuff. And a circulator may also ask you, what all did we do in this procedure? Because they're back doing the chart. Hey, we did a small bowel resection. We did take out the appendix and the gallbladder. So they will have those specimens. However, did you do lysis of adhesions, et cetera, et cetera? To promote employer relations within the surgical team and between them and other hospital departments. So we want to make sure if the patient is going to ICU or the blood bank, or we need to communicate with the blood bank that we need units of blood, that we communicate appropriately. To promote teamwork within the surgical environment, whether that be the CRNA, the radiology tech, pathology, etc. We want to make sure that there's definitely a teamwork atmosphere. To provide continuity of patient care as efficiently and cost effectively as possible. So make sure and have your materials in the room, but don't open a ton of materials because they may not be used. So hold the stapler, maybe hold the cement. We want to make sure and identify the patient's needs. To ensure that legal aspects are considered. So legal, such as maybe they don't want a blood transfusion, okay? Or what are the policy and procedures at your facility regarding a DNC? Or maybe, or here's one, legal wise, if you have a patient that is shot by police, that bullet has to be given back to the policeman. And so there's a ton of paperwork, but that bullet has to be handled appropriately according to the policies and procedures of that healthcare facility. So I know at St. Al's, if the bullet is removed by the surgeon and then touched by the surgical tech and then touched by the nurse, all 3 of those people's names and titles are listed on a document and given to the police. Objective 10, communication requirements of the surgical team. Listen carefully and speak clearly. And sometimes your surgeons don't speak very clearly. So you really develop an operating room ear to dissect and kind of, translate their mumbles into what they need and want. Communicate professionally by understanding and using correct medical and operating room terminology. Don't send your nurse out, hey, I need a whatchamacallit. It's not gonna work. Communicate therapeutically with patients and their families. Always be respectful. Follow verbal directions quickly and directly. Respond to and use nonverbal techniques of communication. And that's kind of what I talked about earlier, right? So when you're going in to give someone a break or a lunch, there's certain hand gestures that we use to where you don't need to verbally speak. Object 11, essential components of effective communication. So you have a sender, you have the message, you have the receiver, and then you have feedback. Okay, and all the message is given, it's received, the receiver gives feedback to the sender. Objective 12, effective listening skills. Deferred judgment. Okay, you don't ever want to judge a coworker, a patient. Again, we don't know what they're going through. We don't know kind of what their history has been. Kind of like what we talked about before. Everybody has a story. Everybody has their own personal things going on outside of the operating room. Listen with an open mind. Don't make hasty conclusions or assumptions. Listen for the whole message. Don't interrupt because you may miss important information. Listen to verbal messages and observe nonverbal messages. Listen for ideas, feelings, and intentions, as well as facts. Pay attention. Sometimes we can be in an environment where it's extremely hard to pay attention. But the operating room is a place that you don't want to miss important details. You know, whether it be what type of implants they're using, what they want to call the specimen, what type of irrigation they want to use, what type of local they want to use. Make sure you're really paying attention to those important facts. Block out visual and auditory distractions. So again, it may be extremely hot. The overhead lights may be shining on you. Focus on the message, not on the speaker. Use nonverbal feedback to let the speaker know they are being understood. Listen completely. Avoid letting your mind wander while you pretend to listen. And I'm sure we're all guilty of that, is that you are off maybe enjoying happy hour with your friends or looking forward to that, or looking forward to the next trip, or I don't know, sitting at home, Netflixing and chilling, whatever it is. Make sure in the operating room that you stay focused. Avoid interrupting and talking. Lots of times in the operating room, we read the situation, okay? So if it's a stressful situation, you shouldn't be talking. Unless it's important facts that you need to send to your circulator or verbally communicate to your circulator. A large amount of our job is reading a situation, reading how is the procedure going, what type of mood is the surgeon in, all of that type of kind of outside type information. Avoid mentally rehearsing responses. Paraphrase what was heard. Dr. Smith, you want a 10 French drain to go in this patient, correct? And maybe he asked for a drain, but didn't verbally say what size he wanted. So paraphrase back. Do you want a 10, you know, did I hear you right? Did you want a 10 French drain? If he didn't want a 10 French, he'll tell you what he wants. When the speaker is finished, repeat in your own words what they said and ask if it is what was meant. If the message is long and complex, jot down notes and refer to them when paraphrasing or performing a task. So inside of your sterile pack that you open up on the back table is a sterile little marker. And sometimes the surgeon will use it, but we use it a ton for certain types of procedures. And we can use it to jot down what is the specimen. Or, hey, maybe your circulator's outside of the room doing something. I can jot down the type of drain he wants, the type of dressing he wants, what type of sutures is he going to close with. Any of that type of information, feel free to write on your back table. Objective 13, effective speaking skills. So we want to assess, plan, present, listen, evaluate. Okay. Objective 14, communication enabling other departments to relate to the surgical suite. Records. Records are super, super important. We always want to make sure that we have the most up-to-date records and that they're correct. Requisitions. So this has to do with lab, right? So are we stating what the correct tissue is? What time did it come out of the patient? Do we have the correct sticker on the requisition? In-service programs. This provides important policy and procedure information. So if a policy or a procedure changes in your department, we also do it with equipment. You may want to know this slide for your test, some of it. Computers. Verbal. Objective 15. Importance of effective communication for the patient undergoing surgery. Communication is the basis for the continuum of patient care and teamwork. So that starts at pre-op. Let's say I'm doing a case with Dr. Jones and he's running a little early. I'm going to call pre-op and I'm going to let them know we're running early and that we're going to come pick up the next patient ahead of time. Patients have a deep need to communicate their feelings or their emotional and physical needs. Patients indicate their needs by what they say and do not say. The surgical team must listen and observe for both types of communication. So sometimes we have patients that tell us that they're okay, but maybe you'll see them squint or close their fist in pain. Maybe they have back pain, and so pillows under their legs would be beneficial. Effective communication can influence the patient's behavior while in the operating room suite and in the hospital later. The patient's attitude towards surgery and healthcare workers. So we don't want to create a hostile environment for the patient. You know, we want to try to be as understanding as possible. Objective 16, techniques for therapeutic communication. Using broad opening statements. Using general leads. Giving information to the patient. Sharing observations with the patient. Acknowledging the patient's feelings. Reflecting to incite the patient to go on, selective reflecting, using silence so patient can gather thoughts. Silence is not a bad thing all the time. If you're looking at them, holding their hand, you know, that allows them the few minutes they may need to gather their thoughts and what they want to say. Clarifying to avoid misunderstanding. Validating to ensure the patient's needs have been met. Are you warm enough? Can I get you another warm blanket? So cliches. So this is what creates a block to communication with your patient. Expression or idea that is overused. Oh, you don't need to worry about that. It'll be fine. Now this is a quick procedure. You'll be okay. You'll be okay. Here's the thing. It can be a quick procedure. You don't know if it's going to be okay or not. They may, you know, try to intubate that patient and maybe they die on the table. So big thing is, don't use cliches. Those reduce your anxiety rather than the patient's. That also minimize the patient's feelings or tells the patient you're not interested. Giving advice is a block to therapeutic communication. Giving approval or agreement. Requesting an explanation, belittling the patient's feelings, expressing disapproval or disagreement with the patient. No, you're wrong, that's not how it's going to go. In the operating room, that is not the time or the place to have that type of response. Defending, and then changing the subject. Objective 18, conflict management. Conflict is a normal part of the workplace as individuals have their own ideas, opinions, and ways of completing a task. Definition of conflict: a disagreement or discord between two or more individuals in which a threat to their individual needs, interests, or well-being is perceived. Conflict is a normal part of the workplace as individuals, oh dang it, sorry, that was duplicated. Poor communication leading to an understanding can cause conflict. Perceived position within a team or organization. A leader, a follower, a role in decision making. Interpersonal relationships. Some individuals prefer to avoid conflict by coping with a situation rather than bringing it to their supervisor's attention. And you will truly see all types of personalities in this work field. So you'll see those that love conflict. They try to create conflict. They thrive in conflict. You'll see others that run from it. I don't care if they're mean to me. I don't want to bring it up. Let's just pretend it doesn't happen. You have others of them that want to face it head on. You know, if there's conflict, let's talk about this. You know, why did you behave this way? This is unprofessional. So just know that everybody will handle conflict differently. Policies and procedures should be in place to address and resolve conflict among team members and/or healthcare staff. Identify common reasons for conflict and develop a plan to resolve the conflict in a fair and consistent manner. Provide training to management and staff that clearly outlines policies and procedures. Address conflict in a comfortable setting where viewpoints can be expressed without fear of criticism or reprisal. And lots of times, if there's a big conflict among coworkers, Both of them will go inside of the manager's office, and then that manager will kind of act as a mediator. So we want to identify the problem, share viewpoints, and truly I think a large amount of the time there would be less conflict in our workplace if we understood what the other person was thinking in their head, or maybe how they were processing the situation. Reach a mutual understanding of what the problem is and what needs to be resolved. Stay focused on the problem, not the individuals involved. Brainstorm and collaborate to help find possible solutions, and negotiate to find a win-win solution for all. A positive aspect of conflict is it gives team members an opportunity to learn from each other and to see each other's points of views, which again, that's huge in the operating room, is being able to, from your circulator's point of view, or maybe your CRNA's point of view. Unresolved conflict can lead to stress and low morale among team members and hamper cohesiveness and productivity. Conflict can be the result of or result in one or more of the following: verbal abuse, inappropriate tone and language directed at an individual or group to demean their position or self-esteem. Lateral violence, unchecked emotions and actions resulting in physical harm and fighting. Bullying, intentional, chronic aggressive behavior toward an individual to cause harm. So the word chronic, that's continuing, constant, prolonged, such as chronic pain. Disruptive behaviors, verbal outbursts, physical threats, refusal to perform tasks, impatience with team members, and an overall lack of cooperation. Hostile work environment, workplace discrimination based on race, color, religion, sex, age, national origin, or disability. And sexual harassment is any words or actions that may cause discomfort to another individual. Most healthcare facilities have a zero tolerance for all of these things, all these negative things we just talked about, whether it be sexual harassment, whether it be retaliation, whether it be bullying, anything like that. All of our healthcare facilities have a zero tolerance. All right, any questions?
No, I think it makes sense. Yeah.
Okay. Sorry, go ahead. Was there someone else on? All right, so big things. PowerPoint presentation is due July 18th, right? Does anybody have any questions or concerns regarding their PowerPoint presentation? Please email it to me. Do not submit it. Next thing is the discussion boards. Remember that you have to create a thread first before you will see the material. So you want to write your thread, your original thread, answer all the questions, and then respond to 2 of your classmates' posts. What else? If you want points on your test, and they were the questions that we talked about today, you have to send me an email. I am not going to correct the test and give you more points unless you send me an email. And that's because I want students to kind of take an initiative. I want students to listen to the lectures so that they get important information. So I think these are just some of the questions that were kind of controversial, that we said it could be both. And we talked about the other answers that would be accepted. Question 5, 22, 27, 32, and I think 33. Don't hold me to that, but if you really re-listen to the lecture, you can kind of go over it. I'm trying to think, anything else? So is everybody going tonight to the Da Vinci presentation?
I know I am.
Awesome. Oh, I'm hearing lots of pings. Perfect. You will love, Alex is the rep. She's fantastic. The Da Vinci has really changed the way that we do surgeries. So, you know, before when we would do prostates, I'm trying to think what else, lobectomies with lungs, partial kidneys, nephrectomies, anything like that. You know, those procedures could have been big blood loss type of procedures. And the Da Vinci has really changed patient care and has made it a minimally invasive procedure. So when we took out prostates 25 years ago, it was a 1,500 to 2,000 liter blood loss on every single one of those cases. And the patients would stay a week to 10 days. Now with the prostates, they can go home within 24 hours. Nephrectomies, same thing. You know, it used to be huge blood loss cases, same with the partial nephrectomies. And now those patients can go home within, you know, 24 to 48 hours. So teeny tiny incisions, kind of like what we talked about at St. Al's. One of the great things about Da Vinci, or kind of like one of the dreams that they had, was that the surgeon could be in New York and control the robot in Paris. So you could have surgeons from all over the world doing surgery at any particular place with Da Vinci because of the cables and the routing systems of the information. So it's a pretty incredible piece of equipment. If you work at St. Luke's or St. Al's or West Valley, Da Vinci cases are a large part of the volume for general surgery. So at St. Al's, you know, there's 2. At St. Luke's downtown, I think there's 3. St. Luke's Meridian, there's 2. And I think West Valley has 1 or 2. But it's an incredible piece of equipment. I'm hoping that Alex will let us sit at the console and kind of actually get to work the robot, because it's pretty neat. All right, anything else? There is one AORN video that goes along with this material. It's effective communication in the peri-op setting. Please print off the packet that's inside the module folder. Look over the questions at the very end and look at the answers. There is 1, 2, 3, 4, 5, 6, 7, 8 questions from this AORN packet on your tests. Now that I've told you that, I expect everyone to get 100% at least on those 8 questions, okay? So again, it's on page 8. If you just print out that packet, go over those questions after you've watched the video or read the material, and then the answers are on the following page.
All right, sounds good.
I'm trying to think if there's anything else. I'm going through the test quickly, but I went through it last night and last week, and I think it's pretty self-explanatory. For the material that we've covered. So, all right. No more questions, concerns. Have a great day. Make sure you guys are staying cool, stay hydrated, and we'll plan on seeing you tonight.
Angela, sorry, I have a question. When do you have the office hour?
When is my office hours?
Yes.
Anytime you want.
Do you
So
have
originally we were doing Thursday 7 to 9.
Oh.
But Thursday night 7 to 9. But I know that people work, you know, and have family lives and that type of stuff. If you want to go over stuff, feel free to text me or email me, and I am more than happy to set up a time. Alessandra, in fact, I can meet you at St. Al's if you want, you know, after you get done with your shift or before your shift or whatever. We can meet there and go over stuff. We can come into the lab and meet if anyone wants to do that and go over material. Okay. Again, it's super hard sometimes to teach this material online. So.
Yes, I would like to talk with you. So I write an email. Perfect. And we try to.
Do you want to? Yeah, if you want to text or email me, please feel free, and we'll be happy to figure out a day and a time to go over the material or answer any questions or concerns.
Okay, thank you so much.
Oh, you bet. All right, anyone else?
Yeah, I have a question. Do you plan on having like a review session before the finals?
I do, yes. And I think Jordan and I were going to kind of talk about that and see if we could figure out a good day for that to happen. Originally, we had talked about doing it in the lab. I'm not sure if that will work with everyone's schedules or not, but I know that that is one of the items we're going to cover tonight at the Da Vinci presentation, is if you guys want to have it, do you want to have it online? Do you want to have it in person? We could even do a hybrid and do both. So absolutely. I will tell you, for the final, the questions will all be off your prior 7 exams. So if you print off those exams and make sure you have the right answers, you will do well.
Okay, thank you.
You bet. Any other questions, concerns?
Oh yeah,
All
just
right.
really quick. Oh, sorry. I was trying to get to the
You're
button.
good. Go ahead, Ray.
All right. So the questions that you said that were